session, we will be giving you the lecture certificate of appreciation. Now, I request Dr. Jayan Srivastava sir, Advisor Quality and Patient Safety, NHS RC, to welcome the participants and enlighten us with the objectives of the lecture. Over to you, sir.
Thank you, Siddhi. Very good afternoon to all the participants. At the outset, I extend a very warm welcome to our ED, Major General Professor Atul Kotwal, who has been having the multiple priorities, but still he took out some time to be with us and addressed all of us. And this initiative is being solely driven by Professor Sangeeta Sharma, who is the driving force behind this collaboration between NHSRC and Delhi Society for Promotion of Rational Use of Drugs. And this lecture series was basically conceived as an effort to build upon the clinical capacities, to refresh our knowledge and to know that what is the latest development in a particular field. And the topics which are being chosen are keeping the requirement, what is relevant for the primary healthcare setup, secondary healthcare setup, and of course, a kind of refresher for the tertiary healthcare, because we appreciate that there are participants from all these three levels of health facilities. And a few words about this choosing a particular topic. All of you may recall, those of us who are working from in the National Rural Health Mission, when it was conceptualized and launched in 2005-06, that promoting the institutional deliveries have been one of the stated objective of the NRHM-NHM. And a substantial gain have been made as a country as a whole, and few states in particular. But the critical challenge comes up that, of course, without undermining the country's effort in moving towards attainment of MMR, maternal mortality ratio, and IMR, but still the birth asphyxia remains a challenge, and all over. In that direction, though many initiatives like Muskan, Laksh, under the National Quality Assurance umbrella has been undertaken, but certain critical challenges still remains. And in this context, it was decided that let's refresh our knowledge and let's try to identify that what are the doable things in the field. And in this direction, other than Professor Sangeeta Sharma, we have a very eminent speaker, Professor Ashish Jain, who would be joining the webinar a bit later. He is clinically occupied around say 3:45. He will be joining himself, who is a professor and head of Department of Neonatology, Maulana Azad Medical College, to speak. So without much ado, I would request our ED, Major General Professor Atul Kotwal, to deliver the inaugural address, and then we can take it forward further with the discourse. So,
sir, before he starts, there is a pre-test link in the chat box. Please fill up that. Right now, we have got only 40 responses, whereas I see there are more than 80 people in the room. Kindly do that if you are looking for a certificate. Attempt on this pre-test and post-test is important, and also it gives us an idea about what are the problems that you encounter, so that the same can be addressed during these sessions. Thank you, sir. Please, sir.
Thank you, Dr. Jain Srivastava, sir. Thank you, Dr. Sangeeta. And I must, first of all, commend all the participants on a Saturday afternoon, the specialists, medical officers, staff nurses, CHOs, and all the other healthcare workers from states who have joined us today. And in fact, every alternate Saturday we have been having this. It's almost more than a year. It's the second phase of this Saturday afternoon lectures. very good afternoon to you all. And the topic of today, as mentioned by Dr. Jain Srivastava sir, also the advisor QPS mentioned, the birth asphyxia, also known as neonatal asphyxia or perinatal asphyxia. That's lack of blood flow or gas exchange to or from the fetus in the period immediately before, during, or after the birth process. So we have targeted the mortality. We proudly mention our achievements of maternal mortality ratio, the infant mortality rate, under 5 mortality rate, and in fact, neonatal mortality is something which is being addressed now. It is reducing. It is reduced to to a large extent, and there are 4-5 states which have achieved the target of SDG also. But now we have to, while addressing the mortality, we also look at the quality of care. And I think birth asphyxia is linked with the quality of care during the intrapartum and also antepartum. So that's why I think this topic is very, very important. And because quality of care is a sine qua non as far as our provision of healthcare services is concerned. And it's, the birth asphyxia is currently the 5th largest cause of under 5 child deaths after pneumonia and diarrhea, neonatal infections, and also complications of preterm births. And almost, the 23% of newborn deaths are caused by birth asphyxia. So, but the beyond this mortality, there are some with some minimal amount of asphyxia which may lead to, the consequences as such. So we have to. That's why I said addressing both the mortality as well as the morbidity it causes of those which have borderline or minimal asphyxia, and they can develop severe consequences such as epilepsy, cerebral palsy, developmental delays, and so this the DALI's disability-restricted life years of birth asphyxia exceed those due to all childhood conditions preventable by immunization. And as per WHO statistics, between 4 and 9 million newborns develop birth asphyxia each year all over the world. So it's a major issue, and that is why I'm very happy to note that this topic has been chosen by the Quality and Patient Safety Division of NHSRC. And as you all are aware, we are conducting these webinars in collaboration with DSPRUD and almost the dedicated team of Dr. Sangeeta Sharma. And the response is heartening with the large numbers in every webinar, and also your pre-test and post-test also. And one can one has a sense that it's a very welcome move, and which is being liked by the participants, and that's why the numbers are there. And we have 2 talks today. One will be preventing birth asphyxia by Dr. Sangeeta Sharma. Other would be birth asphyxia causes, symptoms, and treatment by Dr. Ashish, who is a professor in Department of Pediatrics at Loknayan Hospital, New Delhi, and who will be joining us subsequently. And these, I think, will help you to manage the condition more efficiency and primarily, and rather prevent it first, basically. And that's what is most important. And finally, I think without further ado, I wish all the very best to all the large group of specialists, MOs, CHOs, staff nurses, and other professionals from different disciplines who have joined here today. I'm very sure that you will benefit from this, and you will be with us subsequently also in our other endeavors, and also the discussions like this subsequently also. And I would also like to say that in the post test of today, or maybe subsequently, you could also mention few subjects which you would also like to be discussed here. You can just mention that additionally somewhere, or otherwise in the chat box today you can mention. We have our Dr. Siddhi Don from QPS who will be, who will note down all that, and we'll try to address those topics also. I would like to thank the organizers, the QPS team, and the DSPRUD, Dr. Sangeeta, for organizing this and giving me this opportunity. Wish you all the very best for this webinar. Thank you very much.
Thank you, sir, for the enlightening words. Now I request Dr. Sangeeta ma'am to walk us through the management and prevention of birth asphyxia. Over to you, ma'am.
Thank you, Siddhi. Can you see my slides? Yes.
Yes, ma'am.
Yeah, it is visible.
Okay. Thank you, sir, for your kind words and setting the scene here. Why is this subject very important? Although we have made a lot of improvement in bringing down the mortality, infant mortality rate, and particularly the neonatal mortality rate, but still there is further scope, and we need to reduce. We need to reduce the burden of this deaths caused by birth asphyxia, and largely the topic has been chosen because to quite an extent this birth asphyxia can be prevented. So it is not necessary that the children have to suffer this, although it is a multifactorial problem. We will go through this. Why is this important, and then what are the challenges? In my presentation, I will talk about what goes wrong, or what are the practices where things go wrong, and untoward outcomes happen. So how can we use the standard treatment guidelines approach to improve upon the outcomes for both mother and the child? So that is why this topic has been chosen. And as you know, this is known by perinatal asphyxia, neonatal asphyxia, but it is what we meant is that during the birthing process, if the child does not get enough oxygen before, during, or after birth, the child suffers from insufficient oxygen supply to the brain, and the magnitude of this insufficiency can vary, but if it is severe, it leads to hypoxic ischemic organ damage in the newborns. This may lead to immediate fatal outcomes or severe lifelong pathologies. So that is why it is very important to address this problem at the time of birth, and largely if we can prevent this. I need not go into the details of the statistics, but what is very important is that with the birth of 25 million children each year, India accounts for 1/5 of the world's annual childbirths. So 1/5 of annual childbirths happen in India, but unfortunately, every minute one of these babies dies. So, and currently 1/3 part of all the neonatal deaths registered worldwide occur in India. So 1/5 of the birth in India, but the death rate is 1/3 of the world death rates reported. So you can imagine the extent of the problem, and nearly 46% of all these maternal deaths and 40% of the neonatal deaths, they happen during labor or the first 24 hours after the birth. So the major causes of these newborn deaths are prematurity, neonatal infections, birth asphyxia, around 20%, 1/5, and congenital malformations in small percentage of these. So this is the magnitude of the problem. And if you look at the action plan, India Newborn Action Plan, they have envisaged that this is a preventable newborn death to achieve, and we want to achieve single digit neonatal mortality rate by 2030, with all the states to individually achieve this target by 2035. Although you may think that it is long, here in this action plan report they had done the situation analysis, and they found that we could achieve, the less than 10 was only in Kerala, Tamil Nadu was 11 to 15, Maharashtra, Punjab, Karnataka, West Bengal, it was 21 to 25. But but there were many states where it is more than 30. Chhattisgarh, Madhya Pradesh, Orissa, Rajasthan, Uttar Pradesh, and many states this kind of data is also not available. So you can imagine the extent of problem of this. And if we want to achieve the goal to decline this preventable death to single digit, the road ahead is quite far away from achieving. So how do you achieve this? One of the ways of doing it, APGAR score is a quick assessment tool that is used for assessment of the child's condition, looking at the appearance, pulse, grimace, activity, and respiration. A score is assigned to the child. From score varies from 0 to 2. If it is the child is blue or pale, score is 0. But if there is no cyanosis, no blueness, and baby is pink, then score 2 is given. Likewise, each of this component of this acronym, these have been categorized. So this is very frequently used. Then based on this score, the birth asphyxia magnitude is categorized as mild asphyxia. If the score is from 7 to 10, 10 is the maximum score. Moderate asphyxia if it is 4 to 6, severe asphyxia if it is 0 to 3. So this is a quick assessment tool. Although this predicts lesser the score, higher is the mortality, but this is a short-term predictor only. For long term, this is not a good criteria for measuring the long term complications, because this is birth asphyxia. As I said, it does not only lead to immediate mortality, but it leads to long term mortality as well. So and if the best part is, if immediate medical intervention is given to support the baby's breathing and circulation, long-term side effects or the complications can be avoided. These long-term effects can vary at the time of birth, immediately after birth, from no noticeable effects to developmental delays and neurological impairments. These The blood-brain circulation, generally it has been seen with mild asphyxia. These children, when they grow, they may have ADHD. As the severity goes on, they may have psychiatric problems, issues later, or neurological problems, palsy. All these long-term complications can be seen if this is not immediately intervened. So therefore, early recognition is very, very crucial in minimizing the impact of birth asphyxia on a newborn's health. So challenges, the biggest time factor is very important here. Timely recognition, especially if you recognize in time, intervene in time, the blood circulation to the brain can be restored. But this becomes challenging in situations where continuous fetal monitoring facilities are not available. So the fetal distress can be perinatal period, so if that is recognized, distress is recognized and intervened, perhaps you can prevent this. Resource limitations, lack of essential equipment, trained personnel, facilities to provide adequate resuscitation and post-resuscitation care is equally important in these children. Dr. Ashish Jain will be talking about it in detail. Although there are various programs, the Government of India has launched various programs, but yet there some kind of resource limitation is still there, particularly for the post-resuscitation care. And largely, even if you have personnel, facilities, lack of or poor coordination, interprofessional communication between various teams, nurses, doctors, and other people, this may hinder the coordination of resuscitation efforts and subsequent care. Then variable training levels or experience of the healthcare providers, the obstetric teams, the neonatal care providers, and vis-a-vis updated evidence-based practices, whether there is a consistency in the practices that are followed. I was just looking at the pre-test responses just before the session, and I saw there was a lot of variation in the responses from the various teams. So this is something, this series, the attempt is to bring down, to reduce this inconsistency in care, to bring or make it aligned with the standard treatment practices that are evidence-based. Then, of course, access to emergency obstetric care is very important. This includes um, facility for cesarean sections, and particularly I've visited many health facilities, and I found that many of they although they have the good infrastructure for delivery and neonatal care, but all this is fine for the daytime. At night, there is a issue of availability of the obstetrician or the pediatrician over there, or the facility for conducting the cesarean section at night. So access to emergency obstetric care is something that if we are able to provide, this problem of asphyxia can be tackled. Then other challenges in the management of asphyxia are definitely it is because of there is no one single cause for it. There are multiple factors which can result in, that may belong to maternal factors, fetal factors, and the placental issues. If the mother is having risk factor, hypertension, diabetes, these problems, then fetal issues could be there, placenta accreta is there, or there is abruptio is there, so blood supply to the child is not taking as it should be. Then, as I said earlier, long-term follow-up is a big problem. We are able to take care of the immediate problems, but long-term follow-up is missing to identify the potential developmental delays, neurological issues, and other consequences in the child. Then a very big dilemma or ethical dilemma may arise, particularly when you have to make a decision about resuscitating or continuing the resuscitative efforts or life-sustaining interventions in a child. When do you discontinue, or should you continue this indefinitely? Because especially this also becomes important. The longer the child is not able to breathe, ventilation could not be ensured, larger is the damage to the brain. But if you especially if you are not able to provide the long term, improve the long term outcomes, this brings us to the ethical dilemma. When should it be terminated? And it is a very sensitive issue for the parents, families as well. There have been instances in the news, where the child was declared dead, but later started breathing. So people may construe this as medical negligence, and may get us all into difficulty. So for this, how do you, for how long do you continue? So there needs to be a standardization for the same. During this session, we'll be talking about this. And of course, psychological support is needed for the mother and the family, because this involves a lot of stress and has an emotional impact of these situation on them. Now, there are some of the misconceptions, which are there, which we need to understand this. If we understand this, the perhaps the management could be better. Many of us think that this is a problem only caused by a difficult labor. While this is an important cause of birth asphyxia, but then other factors, like placental issues, infections, maternal infections, or congenital anomalies, they also play a role. So just don't think that it is a full-term baby, or mother had a normal delivery, this problem won't be there. Since there are other factorial issues involved in it, so keep that in mind. And some people think that all newborns with low Apgar scores will have long-term disabilities. While this is an indicator for immediate newborn health, but it does not necessarily predict long-term outcomes. So just don't depend on the Apgar score. You have to look for the developmental delays and long-term outcomes separately, beyond this Apgar score. Then this asphyxia only occurs in premature infants. Again, this may happen. This is an important factor for birth asphyxia, but many infants with low Apgar scores, they recover fully with timely and appropriate intervention. So focus, irrespective of the Apgar score, focus should be on the timely and appropriate interventions. Then some people think that once a baby is resuscitated, the risk of complications is eliminated. While the premature infants are at higher risk, but this can happen in full-term infants. So close monitoring, appropriate post-resuscitation care to identify and address potential issues is very, very crucial, because this always, you don't get all the symptoms at once. They may develop in hours or days following birth. So keep you post resuscitation care is also very, very important for the baby. Then as I said, many people think that all cases of birth asphyxia are preventable. While this is important, largely you can prevent this, but not all cases are preventable. Unforeseen complications can arise during labor and delivery, so you have to be careful during the entire birthing process. Then oxygen should be administered. This is another area of concern, how and what percentage of oxygen should be administered. Many people give high concentration of oxygen without monitoring. So high oxygen concentration can lead to oxygen toxicity. So this, how much oxygen is needed may vary depending on the child's condition, but in many instances room air may be sufficient in some cases. So you have to don't give high concentration of oxygen without monitoring. Then once the baby starts breathing, the risk of birth asphyxia is over. Again, this is not true. Complications may arise later, and these may not be immediate, may come up hours or days later. So regular follow-up is required to address the subtle signs or complications. And you can devise appropriate interventions based on the cause and severity. Now, as my subject today is, how do you prevent birth asphyxia? Because largely you can prevent it, and with good antenatal care. If you have regular and comprehensive prenatal care for early identification and management of maternal conditions like hypertension, diabetes, infections, this can largely reduce the risk of birth complications overall. So regular, that is why emphasis is on completing the antenatal visit, emphasize on the mother to have these visits and look for these. Then, of course, infection prevention and control for healthier intrauterine environment, reducing the risk of birth asphyxia. Then, monitoring fetal well-being during pregnancy, especially in these high-risk cases of hypertension, diabetes. This can help detect and address potential issues promptly. If the child is under distress, interventions can be done to prevent this asphyxia. Then maternal nutritional support. This will support the fetal growth and development, again reducing the IUGR, intrauterine growth restrictions, and associated complications here. So, these are the main strategies how you can prevent birth asphyxia. How do you do this? Then again, there were certain things that provider was supposed to do. Then educating mothers for timely medical attention is very, very important. They need to be prepared for this. You have to provide education to expectant mothers about the importance of the visits, antenatal visits, healthy lifestyle choices, and recognizing the signs of potential complications, fetal movement. They need to be when to, I've been to many health facilities. They say the women come, many of them come in the second stage of labor, almost very late, at the end of the first stage of labor. Perhaps I had thought about it, why does this happen? Have we not prepared these women when to seek medical attention? These women are taken directly to the labor room where they deliver just within 15-20 minutes. You don't even have enough time to prepare for birthing. But this, they say, all the time it is said, oh, यहाँ के लोगों को नहीं मालूम, they come late only. Perhaps then we need to step up our community education or preparation of the mother, expectant mother, when to seek to identify the labor process has started, and when so that they reach the health facility in a timely manner, and the fetal well-being can be monitored accordingly. Then optimizing the timing of birth. This is all unnecessary delays in delivery should not be there, and ensuring that skilled birth attendants are there. The pediatrician is there, the obstetrician and other staff, nursing staff, they are skilled to manage and resuscitate the child. Then continuous monitoring of fetal heart rate is important, and maternal contractions, prolonged labor. One can expect that the child may have distress. So the distress, once you recognize this can be intervened. Then complications, what are the signs of fetal distress and other complications during labor and delivery? If you know then only you will be able to prevent this. Then for this, that is why a lot of training programs are being envisaged for proper use of delivery methods, assisted deliveries, cesareans, resuscitation care, and then postnatal care is equally important, that the baby's vital signs and addresses, so that these complications can be prevented. Now, these were the prerequisites. Then there have been protocols for management of newborn care. But there are issues of difference of opinion, degrees of skills, as I said, may vary, or standard of care may vary from different levels of health facility. So how do you address these? Standard treatment guidelines is one approach. This is a time-tested tool to promote rational use, or in other way, rational use of medicines, and to improve the outcomes. Particularly when we are talking about birth asphyxia, we are concerned about maternal and neonatal outcomes. So standard treatment guidelines is a time tested tool. We need not look here and there. People, experts have looked into it. They have looked into the evidence. They have critically appraised this, about the quality of the evidence. So depending on that, recommendations are drawn in the standard approach to the management of a condition at hand. So as you look at the definition, these are systematically developed statements to help the practitioners make decisions about appropriate treatment for a particular clinical condition. So now, everyone all over the world globally are using the standard treatment approach for the management, because there are, some science is settled. You don't have to experiment or innovate or be creative here. Certain requirements are minimum standard requirements that one needs to fulfill. There are various organizations who've been where these guidelines have been referred. Some are general documents where many diseases have been discussed, like Clinical Establishment Act, NHSRC has developed, ICMR has developed, the Quality Assurance Program, NQAS, this has been a driver here, particularly for neonatal resuscitation program and home-based newborn care. Government of India also have developed these. This IAP, Indian Academy of Pediatrics, this one is the latest one, 2022. So these guidelines are there. One can go through these guidelines and find out. One of the biggest advantage of the standard treatments is that the patients here, they get consistency amongst prescriber, they get most effective treatments prescribed, and of course the outcomes are better if standardized, consistent care is provided. Now, these guidelines also help you in resource allocation, how the manpower should be there, what all basic facilities should be there, SNCU should be there, what all should be available in the SNCU. So these accreditation programs, the NQAS program has helped to a great extent. Otherwise, because we have a lot of pressing problems, compelling problems here. For example, on mother and child health had been the focus of the Government of India largely, but now if you look at your the outdoor attendance or the morbidity pattern, you'll find other diseases, non-communicable diseases, are also becoming equally important. The extent or the magnitude is equally important, like diabetes, tuberculosis, cancer. So under that setting, one may the resources may get skewed towards one program. So this will help you. What is the minimal requirement that you need for providing adequate care? STG help you in that. And of course, this adds value to the health system. You get the standardized evidence-based protocol up to date. Experts have looked into it. You can just see to it that these are followed properly, because otherwise, you may, it is very difficult in today's world to keep yourself updated, because every day at least 1,500 to 2,000 articles are uploaded on the internet, and it is humanly not possible for all of us to go through the entire evidence that is available on the internet. And also, even if you find time and you look at those articles, it is many times because you need a critical skills to appraise that evidence, whether it is good enough for your setting in your context or not. Because there may be, most of the time when you get this literature on the internet, it is the latest advances, or you may not have that facility available. You may be struggling to have a full-time on-call pediatrician with you to have a skilled birth attendant. So you have to contextualize this. So standard treatment guideline, when you get from ministry or NHSRC, they already look into the this issue and the infrastructure available. And of course, it reduces the use of unnecessary, ineffective and harmful intervention. I told you high oxygen concentration without monitoring can be harmful for the child. And of course, it brings transparency, accountability and value to the money. So adherence to these guidelines will improve the outcome if there is a consistency in care. It shouldn't happen, the birth which takes place at the primary care level, the standard followed is different, whereas the delivery taking place at a tertiary care, the different standards will be, the standards remain the same. Only difference may be the availability of the infrastructure. So depending on that, the patient may be referred, the referral criteria would be different for different levels, but the management remains the same, and you follow the evidence-based practices. And early detection and intervention is the mainstay of the management if you want to avoid this. So then the guidelines will help you in optimal resuscitation practices and clear instructions on these practices for newborns experiencing birth asphyxia. So for this, you may need guidance on the PPV, positive pressure ventilation, chest compressions, and administration of medications if necessary. Then STG also help you in identifying the risk factors and managing these risk factors for both maternal, how do you do this? By maternal monitoring of fetal well-being and addressing these complications during labor. And based on this, then you can devise programs for training and education and interdisciplinary collaboration between maternal and neonatal care, so that there is a common framework for communication and decision making. So the risk factors, you may already know about this, which contribute to development of birth asphyxia are prolonged, difficult labor, umbilical cord issues, compression, entanglement, prolapse. These can, compromise the blood flow to the baby, placental abruption, or other issues, maternal hypotension. This can this can also be a problem. Infections, meconium aspiration, fetal distress, prematurity, and multiple pregnancy. Again, these are the risk factors. Maternal hypertension and hypotension both are problem. Maternal diabetes, and especially if it is uncontrolled, it leads to macrosomia, large birth weight babies, and again this can compromise the blood supply. So maternal substance abuse, inadequate prenatal care, IUGR, these are all the risk factors. Now, again, where STG will help you in prioritizing this treatment is that, different people may have different notions, but the most important critical step is that you establish effective positive pressure ventilation. All others, take low prioritization. This one is the most important. So this will help you. It defines the goal of treatment. When do you terminate the resuscitation efforts. For example, many people may have, if the Apgar score is normal, or the child is having normothermia, or they may look for long-term neurological outcomes. That's not the outcome. Here the goal is that the child achieves a spontaneous breath and a heart rate of above 100 beats per minute. That's the goal. So this is the standard goal. Then if you look at another very controversial issue, where the difference of opinion may be there, or the practices may be there, is use of anti-epileptic, whether the child had seizures or no seizures, whether these anti-epileptics would be required, not required. So some may give it for some doses, or some may continue it for 1 month, or some may think that if the baby is normal, then or they may give low dose of convulsant. These are not needed unless the child is having clinical seizures or electrical seizures. There is no role of prophylactic anti-epileptics. I think Dr. Ashish Jain will be talking in detail about this. Now, another very important area is, when do you terminate the resuscitation effort? When do you declare? When do you think that your resuscitation is not going to help you? So again, this has been largely standardized for people, but you may have to look at the your circumstance. But generally, it is said that resuscitation efforts after 20 minutes of zero heart rate recording, then you think that the resuscitation has not been successful. So STG will help you there. Then, as I said, definitive directions are provided in the guidelines, for oxygen therapy. Start positive pressure ventilation with room air. Room air is generally 21% oxygen, so 100% is not needed. You can start with room air, and so that's the definitive direction here. Then postnatal care, how do you monitor, what intervene? Then feeding issues in these children, all these guidance is provided in the postnatal care. So just to summarize, the standard treatment guidelines, this is the concept actually. If we understand, we will be able to follow this. These are disease oriented mini manuals. They focus on the management, and they provide stepwise management to you, that this is how you go, how do you assess the response, and then step up your interventions. And equally important is the stepping down of the treatment. We have seen in clinical practice, leave aside birth asphyxia, we are all very good at stepping up therapy. We add, hypertension is not controlled, or diabetes is not controlled, or asthma is not controlled. You go on, stepping up treatment, add drugs, or increase the dose or frequency. But once the patient is stabilized, that we see that the patients are not stepped down. So you have to either decrease the dose frequency or take out the unnecessary medicines. So standard treatment guidelines help you in identifying the step up, step down, and if the patient is having comorbidities, they help you in selecting the optimum therapy. So they are the guidelines. They are not the law here, but generally it is said strict law which punishes those who deviate from the guidelines. So you should have enough reasons to deviate from the guideline. Why is it that you did not follow a standard of care? Many a times when these medical negligence or violence litigations, this happens in the health facility, people think for the patient, any adverse outcome is taken as negligence here. So for it, the onus of proving that the just a minute. Okay. So you should have enough reasons, why a standard care was not followed. I have got this, latest, this was the news where doctors were banned because they could not follow the standard of care. So we have to be really very careful about this. So it is also important to adhere to, treatment protocols because it standardizes care, resuscitation, steps, protocols that need to be followed, stroke care, because again, like in birth asphyxia, for adults, if there is no blood supply to brain, the time is a critical factor. So stroke care, timely intervention is very important. Then unnecessary prescriptions for antimicrobials, anti-epileptic medicines like in prophylactic anti-convulsants in birth asphyxia. Today is the first day of the World AMR Awareness Week. Wow, this is called WAAW 2023. This is a week which is celebrated every year to commemorate or to improve the awareness about antimicrobial use and the problem of AMR. So it commences that. So it is again relevant here. Unnecessarily, I have seen that even normal delivery patients, they are getting Cefixime as a routine medicine, as a routine package. They get 3 medicines: Cefixime, diclofenac for pain, and pantoprazole, because diclofenac has been given. So this is an unnecessary use. Although infections are an important cause of birth asphyxia, but not all women would need infections. Prevention is better than cure here. And of course, one can save lives and improve outcomes through data analysis. If you just look at it, many times when we go for assessment, we find that they are just presenting the data. You have to analyze that data. What is that data trying to tell you? So unless you speak to that data, you will not understand why are we collecting it. And once we know why are we collecting it, it will help us in improving the outcomes. And this can be done by audits and monitoring. If you particularly look at, how many cases of birth asphyxia happened, how many cases it was preventable, in how many cases successful outcomes were there, or what were the, then again, very important aspect for that matter, any disease of concern, particularly, for example, birth asphyxia. Look at, you did the resuscitation, you may be successful in most of the chances, but sometimes you may not. But then you need to look back, where were the gaps? Why was it successful in some and why was it not successful in others? So this can be one of your quality improvement exercises, that you look into it, what are the gaps, and then take up small projects to fill those gaps, so that the better outcomes can be achieved. So a quality improvement, so this can serve you as a criteria for quality improvement. So this is a yardstick that you can use to measure your practices, whether they are aligning with the standard of care or not. So again, I told you the standard treatment guideline, many patients come up with multiple problems. You may be expert in your own field, but you may not know what's happening, or what is the advance, or what is the evidence, current evidence supporting a recommendation for management of other diseases. So many times you need a comprehensive ready reckoner type, so that in a given patient of gestational diabetes, what is the treatment to be given, what is the target, and how do you avoid what kind of. So all these things, this is another resource that you have for following. So there is a dedicated pediatric section here, newborn care steps are provided. So again, the layout, all the essential steps in the management of a disease are included here. It begins with the introduction to the disease, then provides salient features, presenting signs and symptoms, which laboratory investigations are needed, how do you confirm a diagnosis, which laboratory investigations are unnecessary, are also included here. And again, as I told you, all standard treatment guideline would provide you non-pharmacological, pharmacological treatment, and assessment of response is very important. How often do you assess? How often do you look for fetal heart rate? How often do you evaluate for maternal, partograph contractions? When do you get alerted? When should you take action? So all these things, steps are provided in the standard treatment guidelines. And of course, these are evidence-based. Medicines are selected based on the efficacy of the medicine for that management of that particular condition. For example, pain. If pain may sound very simple, that you give any NSAID for that pain, but the drug you choose, there may be other criteria like safety, cost involved, or suitability involved in it. So based on that, you select these, and the guidelines provide you the treatment of preference, the choice in order of preference, and of course, they mention the aim of therapy or goal of therapy. Patient education, as I said, is very, very important. This is the unique feature of this book I just showed you. It helps in empowering the patients about the nature of the disease, whether it is controllable, curable, what is the treatment, is it the course, or it is a lifelong treatment required, what is the natural course of illness, what is the severity, what are the red flag signs, all those things are given in this section. And particularly when you talk about the birth asphyxia, you need to educate the mother and the family about the risks signs and preventive measures related to birth asphyxia, promoting their active participation in the care. So they can help you in identifying these situations. I think I'll stop here. Dr. Ashish Jain is already here. Dr. Ashish Jain?
Yeah, ma'am. Good evening, ma'am.
Good evening. Thank you for joining. Thank you for coming in. I hope your meeting got over in time.
Yeah, ma'am. Before time, so I could.
Okay, that's good. Okay, Siddhi, can you introduce Dr. Ashish Jain?
Thank you, ma'am, for the informative session. If anyone has any queries regarding birth asphyxia, can post their queries in the chat box. I welcome Dr. Ashish Jain, sir. Sir is a neonatologist and professor and head of Department of Neonatology, Maulana Azad Medical College and Hospital, and also associated with Lok Nayak Hospital, New Delhi. Sir is a gold medalist MBBS. He has almost 82 research articles, and he has also authored 22 books. Sir has received four best innovation awards, and also he is MD pediatrician with gold medal. We welcome you, sir, and over to you, sir, for the session. Thank you, sir.
Thank you, Dr. Siddhi, and thanks for the NHSRC for giving this opportunity to be among you people. Can I share my screen?
Yes, you got. Yes.
Yes.
Okay, is the screen visible?
Yes, yes.
Yeah, am I audible?
Yes.
Okay. So I got an opportunity to look at these last part of your talk, ma'am, and really that has given a push to this next talk where we'll actually deal with the core asphyxia and also look at its management. So one thing is very important when we talk about birth asphyxia is that why it's important. So some decade back, it was almost contributing to 1/4 of neonatal deaths. But even after so much of development and so much of initiatives from the government, still almost 14% of our total deaths are attributed to birth asphyxia. So that is the SRS data 2017, which says that almost 13.5% of total neonatal deaths are attributed to birth asphyxia. And if you look at the most common mortality, which is because of the prematurity and low birth weight, even in that category, you will see that almost 30 to 40% of the deaths are somewhere related to asphyxia. So the quantum of the deaths because of asphyxia is very significant, and that's why it is important for every one of us to know about birth asphyxia, how to prevent it, and basic things, how to manage it. Having said that, it's also almost half of our stillbirths are because we are not able to appropriately manage birth asphyxia at birth. And if you look at the babies who have neurodevelopmental, disabilities, major contribution to these neurodevelopmental disabilities is birth asphyxia. So with that background, we all know now that why birth asphyxia is so important to learn, to discuss, and to engage ourselves with certain very obligatory skills which we all should have. If you look at the definition, the literal meaning says that it's stopping of pulse, and the Webster dictionary looks it as reduction of oxygen and increase of CO2. But one thing is very clear, that it is not synonymous with hypoxemia. So hypoxia is not very synonymous with birth asphyxia. So birth asphyxia affects the brain beyond that. It also causes ischemia or reduction in the blood flow to the brain. So asphyxia is in a way combination of hypoxia along with decreased blood supply to the brain. So these two components together actually form the pathogenesis of birth asphyxia and not just hypoxemia. So the WHO gives a community definition: failure to initiate and sustain breathing at birth. That's important for the community workers, but definitely this will bring in too many babies as diagnosis. And we have one Apgar based definition, even though we do not use Apgar now for defining or to initiate resuscitation, but for the collection of data purposes, if the Apgar score is less than 7 at 1 minute of age, then we call it as asphyxia, moderate when it is between 4 to 6, and severe when it is less than 3. So that is the NNPD, National Neonatal Perinatal Database definition, which most of the nurseries in India use. One should always understand that Apgar score has a lot of limitations when you are using it to define or to actually decide on initial and immediate management of asphyxia. So it is not very synonymous. It will not reflect acidosis. Apgar score may be just low because the baby is very small. So you can see that one of the parameters in Apgar score is activity. So if the baby is small baby, say he's 1.2 kgs, he's 1.1 kg. So by his nature of that smallness, his muscle tone may be less. And we may falsely label this baby as asphyxia. So that is one particular limitation. It has a very poor sensitivity and positive predictive value of acidosis. So there may be babies who are having very poor Apgar score, but they may not be actually acidotic and their outcome may be good. And there may be babies who are not having that severe low scores of Apgar score, but still they may have acidosis. So it doesn't actually predict the outcome of asphyxia or the level of brain injury which you see in a baby. Sorry for that interruption. So the definition which is used by the legal system, because this has a lot of connotations, whether it is an obstetrician's fault or it is a neonatal specialist fault. So this particular definition is used wherein all the 4 points should be present to tell that the baby has perinatal asphyxia. The first point is profound metabolic or mixed acidemia. So his pH, cord blood pH should be less than 7 on umbilical artery ABG. There should be a persistence of Apgar score of 0 to 3 for more than 5 minutes, not just at birth or at 1 minute. Even at 5 minutes, his Apgar score should be less than 3, between the range of 0 to 3. There should be clinical neurological sequelae like seizures, hypotonia, coma, HIE in the immediate neonatal period. And along with the involvement of the central nervous system, there should also be an involvement of some other system. It might be GI system, it might be hematological system, it might be renal system. So there should be some evidence of a multi-organ involvement. And when all these 4 things are present, then we define it as perinatal asphyxia. Having dealt with the definition, the frivolous and the basic definition and the legal definition, let us look at the risk factors of asphyxia. So the asphyxia would have risk factors which may be there in the antenatal period or they may be there in the perinatal period. The important risk factors of the antenatal period are if the mother is diabetic, if it's a post-term gestation, if the mother has hypertension, if there are multiple babies, if the size date discrepancy is there, that is the baby is growth retarded, if there's a previous RH sensitization and the baby is hydropic, maternal drug abuse, previous childbirths, extremes of maternal age like more than 35 or less than 16, bleeding in second and third trimester, poor prenatal care, maternal infection, poly or oligohydramnion. So these are certain very important antenatal risk factors that may put the baby at risk of asphyxia. Similarly, if you look at the intrapartum risk factors, the babies who are born by elective or emergency CS, they are always at a higher risk of birth asphyxia. When the babies are born by precipitous labor, prolonged second stage of labor, preterm labor, premature labor, abnormal presentations like breech, bro, footling, cord prolapse, they all are again at risk of birth asphyxia. If there's a rupture of membrane for more than 24 hours, foul smelling amniotic fluid, non-assuring fetal heart rate patterns, what the obstetricians have identified, use of general anesthesia and prolapse cord. So these are the events that can occur in the intrapartum period, which put the baby under heavy risk of having perinatal asphyxia. So how do we actually predict this before the baby is born? So there are methods when we actually monitor the mother at the time of the delivery to constantly see whether this baby is going at a risk of perinatal asphyxia. And if such is a situation and the intrauterine environment is not good for the baby, we will take the mother for an operative delivery and deliver the baby by cesarean section. So we look at the fetal heart rate patterns and the Doppler flow velocities. So you have different patterns, and based on the pattern, if the pattern is persistent late deacceleration, or it's a persistent severe variable deacceleration, or there's a prolonged fetal bradycardia, or there is decrease in the beat to beat variability, the fetal heart rate, these are very telltale signs that this baby may be at risk of perinatal asphyxia. At the same time, babies who have meconium stained amniotic fluid, especially the babies who are not post-term but still have passed stools, because the stool are passed because of some perinatal stress, and hence these babies are again at risk of birth asphyxia. Rarely we do fetal blood gas analysis, it's not done routinely, but umbilical cord blood gases, as we saw, that if the pH are less than 7, again this baby is at risk of perinatal asphyxia. Similarly, we have biophysical profile, where it's a mixed profile of fetal heart rate and as well as the ultrasound, wherein there are components where we score, and based on this scoring we can tell that the baby is at risk of perinatal asphyxia. So that is how these are the risk factors of asphyxia, and that is how you monitor the mother antenatally. Once the baby has asphyxia, what actually happens? How does it pathophysiologically the things occur, that we will try to learn now. So once there is an hypoxia, there is a diving seal reflex. What is this diving seal reflex? The body tries to shunt the blood to less important organs, away from the less important organs to the more important organs. So what are the less important organs for the body? They are lungs, kidney, gut and skin. So you will see often these babies who are having respiratory distress at birth, they will have renal shutdowns, they will have some bloody aspirates, they may look very pale, what we call as asphyxia pallidum, because most of the blood is shifted from these non-important or called as non-vital organs to vital organs like brains and adrenals. So what happens? There is a brain sparing, and this is called as the diving seal reflex. And hence it tries to prevent the brain injury and causes mainly the non-brain organ injury. But if this still further continues, even after the diving seal reflex, then within the brain, the body tries to shift the blood to areas which are more important. So as you have the respiratory centers, the eye centers, the motor centers, everything which is in the posterior circulation, circulated brain. So the posterior circulation is now maintained compared to the anterior circulation. And this is the stage when you will start having cerebral cortical lesions, or blood supply reducing to certain cortical areas, causing brain injury. And based on this particular pathophysiology, you will have different types of injuries in the brain. If you look in the MRI later on, so in the term babies, you will have selective neuronal necrosis, that is at different places in the cortex you will have certain brain injuries. Or you may have status marmorata, wherein predominantly you will have the athertoid and dystonic movements. You may have parasagittal cerebral injury, or you may have focal or multifocal ischemic brain injury. At the same time, if you look at the preterm babies, because most of the activity is occurring around the periventricular area. So this periventricular area suffers the most, and you will have what is called as periventricular leukomalacia. Now we saw that how the diving reflex occurs, how the brain, the blood is shifted to the brain, and within the brain, how the blood is now predominantly shifted to the posterior circulation. But what is happening in the cell? What happens at the molecular level? Whenever there is an interruption to the placental blood flow or the oxygen is interrupted, the first injury which occurs is called as the acute injury. And after that, when you resuscitate a baby, there is a second type of injury which occurs. And this is the permanent injury called as a secondary or the reperfusion injury. So once you have resuscitated a baby, there is a window period of around 66 to 24 hours where some interventions may actually protect the brain. But beyond 24 hours, if these interventions are not given, then the damage is reasonably permanent and there is irreversible. So the primary energy failure which occurs during the acute phase, there is a decrease in the ATP, there is increase in the intracellular osmotic load, the cells get swollen up, there is a free radical injury, there is an increase in glutamate neurotransmitter that causes excitotoxicity and activation of lipases and proteases. And then after that latent phase of 6 to 24 hours, as I was talking, there will be secondary energy failure wherein there will be apoptosis or programmed death of the cells, activation of microglia, reduction in growth factors, extensive glutamate excitotoxicity, free radical and inflammation. So this eventually will lead to permanent brain damage. So the cellular mechanisms which actually cause neuronal death in a baby with birth asphyxia are the total energy failure, reduction in the ATPs overall, excitatory amino acid, that is a glutamate induced toxicity. There will be increase in the calcium influx into the cells, which will cause the damage to the cells. There is also a free radical and the nitric oxide related injury and apoptosis, that is there is a programmed death of the cells which is occurring. So even though this chart looks very complex, but if you look at basically when there's energy failure, there is no oxygen for the sodium potassium ATPase system, and because of which what happens is the sodium potassium and the calcium transport system failure is there. There'll be increase in the intracellular calcium accumulation. At the same time, more water is drawn into the cell, and these osmotic forces will directly cause the blood damage. And also the microglial response will release the inflammatory mediators, which will again cause the brain damage. This intracellular increase in the calcium will cause protease activation, finally leading to cytoskeletal destruction and neuronal damage, and also will lead to phospholipase activation, which will produce the free radicals. And these free radicals will again lead to pro-apoptotic gene expressions, leading to neuronal damage, and also certain endonucleal activation occurs, which directly causes a nuclear injury. So all these taken together will result in the neuronal injury and the neuronal cell death. So based on this particular mechanism, there are different interventions which people have tried. For example, people have tried by reducing the metabolic activity of the brain, so that if the brain requires less oxygen, there will be less damage. So this can be done by giving heavy doses of phenobarb or by putting the baby in a hypothermic environment. So you also have what is called as therapeutic hypothermia, which can be started on the babies. Or you can use calcium channel blockers, which will reduce the calcium to enter the cell. Or you can use certain magnesium sulfate, or again hypothermia, which will actually alter the receptors which are taking the calcium to enter the cells. Or you can decrease the apoptosis by using caspase inhibitors. You can also use certain scavengers which will remove the free radical from the system, like vitamin C and A, or you can use certain alkylators, indomethacin, allopurinol, which all will block the arachidonic acid and generation of free radicals. So based on the mechanism, these different interventions are used. But most of these interventions are still experimental. What options are investigated in humans are mainly Maxwell, allopurinol, hypothermia, and phenobarbital. And to date, the only proven intervention that can help to a certain extent, basically proved in the developed countries, is a therapeutic hypothermia. So in a therapeutic hypothermia, it is easy and feasible. The multi-site studies have shown that there is a reduction in perfusion injury. There's a vast clinical data now available and safety proven in almost all the studies, even though there is some doubts still there whether it works in our developing countries or not. So here you can see that the baby is kept in a thermal blanket. His temperature is reduced to 33.5 degrees centigrade for the first 72 hours, and slowly again he is rewarmed. And this therapeutic hypothermia will reduce, if it is started within that window period, will reduce the neuronal brain injury and be neuroprotective for the brain where the baby has birth asphyxia. So these are the different benefits of therapeutic hypothermia, wherein it reduces the death and severe disability, it reduces the mortality, decreases the chances of cerebral palsy, blindness, and deafness. How do these babies manifest? What are the clinical manifestations of birth asphyxia? So the birth asphyxia, the pathological diagnosis is hypoxic ischemic encephalopathy, what we call as HI. So these babies with HI have altered consciousness. They have problems with the tone. They are hypotonic initially, later may become hypertonic. They throw seizures because of brain injury. They may have autonomic disturbances like abnormal heart rates, beat-to-beat variability, increase in secretions, mydriasis, meiosis, and abnormalities in the peripheral stem reflexes. So taking this all together, we have certain ways how we can classify and stage and grade the hypoxic ischemic encephalopathy. The classical staging of Sarnath and Sarnath is used by most of the neonatologists, where they classify the babies into stage 1, stage 2, or stage 3. So stage 3 is very severe, wherein almost 80% of the babies will have some form of neurodevelopmental delay later in life. Stage 2, around 5 to 20% of the babies will have problems in the later life, and stage 1, almost all babies will be normal except 0.5 to 1%. So this type of staging in the first 72 hours will give you an idea as to how severe the brain injury can be, and accordingly you can prognosticate to the attenders or the parents of the baby. There are simpler stagings like Levine staging, which is used by most of the SNCUs, that is sick care newborn units in the district hospitals, and any one of us also can use it, wherein again it is classified into mild, moderate, and severe, and it has 4 components: consciousness, tone of the baby, seizure of the baby, and sucking. Just based on these 4 examinations, one can decide whether the injury is severe or it is mild, and accordingly one can prognosticate as to what the outcome of the baby will be in terms of neurodevelopmental outcome to the parents who are very anxious and want to know from you. We use in our hospital what is called as the Thompson score. So the maximum score is 22, and if the baby has a score of more than 10, 70% of these babies will be abnormal, and if they have a score of more than 50, almost 90% of these babies will be abnormal. So this again is a way how you can actually grade the brain injury, and it helps us in prognosticating to the attender. So on a day-to-day basis, in the first 72 hours, we will be recording what is the Thompson score of the baby, and accordingly we will know whether this baby will be bad or he will recover from his neuronal brain injury, and what will be the residual effects of brain injury on this baby. So this is the whole Thompson scores chart, wherein this is how you do the Thompson score. There are 9 components, and this is the date and time. We will write the date and time here and go on writing the score, what is the total score, and this information is used for prognostication. And we also write here that at what date, who had explained whom about the prognosis, because that is very important to keep the attenders updated in this era when they get very anxious and angry if you're not communicating to them. As I said, that it's not a single organ disorder, because the hypoxia is a global phenomenon and it injures many organs. So you will see that 50% of these babies will have some form of kidney injury, 28% of the babies will have severe forms of brain injury, 25% heart, 23% lung, and another less than 5% of the babies may have involvement of the bone marrow, bowel, or the liver. In heart, these babies will have reduced myocardial contractibility, severe hypotension, passive cardiac dilatation, and tricuspid regurgitation. In lungs, they may have pulmonary hypertension requiring assisted ventilation. In kidneys, they may have renal failure, which may present as oliguria during recovery as high output tubular failure. GIT, there will be intestinal injuries, there will be necrotizing enterocolitis, poor peristalsis, bleeding from the GI tract, so they may manifest in a similar way if they have the GI involvement. So once we know the clinical features and now we know how to classify the degree of brain injury in the first 72 hours and prognosticate to the parent, let us come to the most important part, that how do we manage these babies. So the management of the birth asphyxia is from the delivery room itself. And in the last talk, we heard about how to resuscitate a baby, what are the important objectives of resuscitating the baby, wherein Madam very aptly said that pushing air for ventilation into the baby's lung is the most important factor while you are resuscitating the baby. Beyond the delivery room, the most important way how you can prevent the brain injury is by supportive care. So whatever injury has occurred or whatever organs are suffering the hypoxic injury, try to support that and see that no more injury occurs. And as I told, that there are also some neuroprotective strategies which you can use in the window period of 6 to 24 hours, like the therapeutic hypothermia, which I discussed in a couple of slides before. So what is this supportive management? The supportive management, as I said, is the most important and essential part of management of baby with birth asphyxia. The management encompasses a large number of areas. One is to maintain oxygenation and ventilation. Second is to maintain adequate perfusion. Might it be by bolus, might it be by giving inotropes, you have to maintain the perfusion. Maintain normal blood glucose levels, maintain normal serum calcium levels, maintain normal hematocrits, and promptly and immediately treat the seizures. So these are some of the important supportive management, spokes of a wheel of supportive treatment which you should do on a baby of birth asphyxia. We often teach our residents that try to remember this mnemonic, and this is like a mool mantra for neonatology. Any disease in the neonatology, we always focus on these particular 9 or 10 things. One is the T, that is a temperature management, airway management, breathing, circulation, administration of fluid, medications, feeds, monitoring of the baby, communication with the parents, and also talking about follow-up. And the same principles we will follow in a baby who has birth asphyxia. Now let us look at these one by one. First is the temperature. So in a temperature, we will see that the warmers are set at a skin temperature at a set temperature of 36 to 36.5. And in these babies, you should never keep these babies hyperthermic because the chances of seizures will increase. So these babies are kept at a range between 36 to 36.5 degrees centigrade. Only if the unit has an experience of therapeutic cooling or passive cooling, then only one should go to temperatures below this. Otherwise, you should maintain the normal temperature between 36 to 36.5 degrees centigrade. Next, coming to the airway and breathing. So these babies, often because of the brain injury, they will have impaired ventilation, which may further contribute and exaggerate the brain injury. So they should be, the position should be changed. Because of the neurological injury, they may have a lot of secretions and needing frequent suctions, which should be done. Mechanical ventilation is indicated if there is a poor respiratory effort, apnea, or ABG in the unexpected range. So these babies generally need very minimal settings of ventilator because their lungs are not abnormal. Only the problem with them is that they are not able to generate their own spontaneous respiration to maintain oxygenation. So minimal amount of ventilation to maintain their target saturations between 90 to 95% should be given to these babies if it is required. Now let us come to the C. After T, A, B, let us come to C. So in C, we will see that we should recognize if there is any shock. So decreased perfusion is seen due to myocardial dysfunction, as I discussed already. And there is if there is a shock and decreased cardiac activity, this will further exaggerate the brain injury. So the baby, if he is pale, mottled, there are weak pulses, capillary fill time is less than 3 seconds, the BP is low, urine output is following, one should always give these babies bolus, and if needed, should start inotropes. And there should be a rigorous monitoring of the blood pressure and the shock status in these babies, because any persistence of shock will further exaggerate the brain injury. Then coming to the fluids, there is tendency for the fluid overload in these babies. So one should be always skeptical about looking at the fluid, what you're giving to the baby, fluid overload should always be avoided. So these babies are generally started at 40 to 60 ml per kg per day of IV fluids, which is free of electrolytes in the first day of life. And then you monitor for the weight gain, weight loss, and the urine output. If the baby is not losing any weight or his urine output is not more than 2 ml per kg per day per hour, then you should not increase the fluid. Keep the baby at 60 ml per kg and monitor the baby for the renal shutdown or the renal injury. One should also look at the glucose. Now we are coming to the drugs or the after the medicines. So these babies will have increased glucose utilization during asphyxia, may potentiate glutamate toxicity, and hence one should maintain the glucose in the normal range between 75 to 100 milligram per deciliter. Soon after resuscitation, these babies these babies should be monitored for blood sugar levels at 6 hours of age, 12 hours of age, 24 hours of age, and see that if they are maintaining their blood sugars in the ranges which are already mentioned. The seizures is a very important happening in these babies, and they come very early. These perinatal asphyxia is most common cause of seizures, and persistent of seizures may further damage the brain because every seizure utilizes oxygen, utilizes glucose, and further causes brain damage. So these seizures will be treated aggressively, but one should remember that seizures in a case of birth asphyxia may also be because of hypocalcemia, hypoglycemia, hyponatremia. So always whenever a baby throws a seizure, one should always rule out whether he is not hypoglycemic, he is not hypocalcemic, he is not hyponatremic. And if all those things are normal, the most likely cause of seizure is his brain injury, and one should go on starting him on anticonvulsants. As Madam said in the last talk, there is no role of prophylactic anticonvulsants in any case in these babies because every anticonvulsant will further cause brain damage if there is no epileptic focus in the brain. So in a seizure is there, you don't have hypoglycemia, don't have hypocalcemia or hyponatremia, one can start with phenobarbital at 20 milligram per kg over 20 minutes. If it is still not controlled, because the liver injury is very common in these babies, we sometimes directly go to the next drug, that is the phenytoin, where we give 2 mini boluses of 10 milligram per kg over 10 minutes, 2 boluses. Still, if it is not controlled, we will use the other alternate drugs like levetiracetam, and later on some of these babies also go on midazolam drip up to 14 to 16 microgram per kg per minute. In feeding, initially when the things are evolving, when you don't know how much the brain injury will be and the baby is acidotic, you can keep the baby nil orally. But the moment the baby has recovered from the hypoxic injury, one should not keep him nil orally, and oral feed should be gradually started on the baby as is showing the signs of improvement. But as we know that the gut injury is also common in these babies, one should always be monitoring for the abdominal distension and normal vowel sounds when you are feeding these babies. What are the predictors of poor neurodevelopmental outcome? So if a baby fails to establish a respiration in 5 minutes, if the Apgars are 3 or less even at 5 minutes, if the onset of seizures is very quick within 12 hours and you are needing multiple anticonvulsants to control these seizures, if the baby has already gone into stage 3 HIE or severe HIE as we saw in the scoring systems, or there is inability to maintain feed by 1 week of life, or there is abnormal EEG, CT, MRI. So these all are the indicators that the babies may have a poor neurodevelopmental outcome, and hence one should quickly communicate about these things to the attenders and counsel them about the outcome of the baby. So in conclusion, if you look at the management of the babies with birth asphyxia, the supportive care is the cornerstone of therapy. So the better the supportive care, the better will be the outcome of the baby. Use room air for delivery room resuscitation, as Madam said in the last talk. Avoid hyperthermia under all circumstances. Even if you cannot give a dedicated, structured hypothermia, therapeutic hypothermia, you should never keep these babies hyperthermic. Hypothermia improves neurodevelopmental outcome. So if the unit is experienced in giving therapeutic hypothermia, one may try it. Safety of hypothermia in our setup needs to be studied before implementation because it is a double-edged sword. If you are not well prepared and not experienced in giving therapeutic hypothermia, one should better resort to only the supportive therapy rather than these particular interventions. So with that, I would conclude my talk, and happy to take up questions. I don't know whether these questions come through the chat box or.
Thank you, Dr. Ashish, for such a lucid presentation. Every time when I also listen to the expert, I also learn. Otherwise, my exposure has been from the programmatic point of view and the standardization point of view, but certainly you gave very deep insights into the management, and also at the same time navigated with the current latest what's going on. Otherwise, many of the people working at the peripheral level, they think they don't know, they are alienated what's happening. So I think it was a very good balance between what's being researched and advances taking place, and what should be the minimum level of care. And I hope all the participants found it useful. Maybe you can start writing. They will write the question in the chat box. Uh, okay, there is already one question. How to stop AEDs for babies on multiple AEDs?
Yeah. So that's a very relevant question, and good that you have brought in that question. So that's from Monisha Biswas. So Monisha, when these babies throw seizures, for example, if you have a birth asphyxia baby and he throws seizure once, and you find that it is a hypoglycemia or a hypocalcemia, then you don't need any anticonvulsant. So that baby, just you need to correct his blood sugar levels. But when he throws a seizure and you see that he doesn't have hypoglycemia or hypocalcemia, then probably that seizure is because of the brain injury. Then you start him on an anticonvulsant. The first anticonvulsant, as I discussed, was phenobarbital. Now, after you start phenobarbital, if the baby doesn't throw any seizure, then you can stop phenobarbital as soon as the baby is seizure free for 48 hours. So you have started phenobarbital single dose. For the next 48 hours, if the baby has no seizures, then you can immediately stop the phenobarbital. Now, suppose the baby has a seizure within 48 hours, he has another seizure. Then you can go for the next anticonvulsant, that is 10 milligram per kg of phenytoin. And then put this baby on maintenance of phenytoin. So the maintenance is given only for that baby who requires the second dose of anticonvulsants. Or else you can straightforward stop the anticonvulsant if the baby has only one episode of seizure. Now, once you have started him on maintenance dose, again follow him up for 2 days. If the baby has no seizure in 2 days, you can stop phenytoin. That is the last drug you introduced. Follow another 2 days. If he has no seizures, you can also stop phenobarb. So this baby, there will be no anticonvulsants at the end of 5 days. And any baby who is getting discharged, try to taper and stop all his anticonvulsants. It doesn't matter whether the baby is neurologically abnormal, or his MRI is abnormal, or his EEG is abnormal. If you find that there are no clinical seizures, kindly stop all anticonvulsants at discharge. So these are the latest guidelines which are there, and you can definitely follow these guidelines, and they have been given by the International League of Epilepsy for the neonatal seizures in 2022. So what is the harm in continuing, you may ask? The harm in continuing that every anti-epileptic or seizure medication causes programmed cell death. So if you give the baby phenobarb for 1 month, 2 months, as we were giving a decade back, that will slowly go on killing his neurons, and he will go into a neurodevelopmental delay. So they are very double-edged swords, and they should not be given unless you have epileptic foci in the brain. Hope I am clear about how to stop the anticonvulsants.
Dr. Ashish, while we are waiting for other questions to come, what about feeding? What should be the feeding protocol for the baby?
So whenever you face a baby with the birth asphyxia, it is a common practice to keep these babies NPO for 48 hours or 72 hours. That is not actually required. When a baby comes with birth asphyxia, it is a spectrum of disease. He may have just a mild injury, as we saw, or he may have a severe injury. So if the baby is in the mild stage, that is, I gave you a very simple stage way to assess, that is a living staging. So you can go back to that table and see that if the baby is falling in the mild asphyxia, then you can start these babies feeding as soon as possible, maybe within 6 to 8 hours. So there is no need to keep these babies NPO. At the most, you can start them on some 50% feeds and then augment them next day on full feeds, so that you can assess the gut, the gut ischemia during this first partial feeding of the baby. But keeping the baby just NPO for 3 days because the baby has asphyxia is not recommended, and it will be hampering the nutrition of these babies. So what commonly we do in our nurseries is that we will do a gas after maybe 6 to 8 hours. If this gas shows no acidosis, then we'll start the baby on feeding. But again, you can also clinically look at the baby. If you find that there are no progressive injury of the organs, the baby is passing urine, the baby has no shock, is not ventilated. So these type of babies can directly be started on feeding.
Dr. Ashish, another question, about the termination of the resuscitative effort, your views on that.
So, we have every 5 years, we have these neonatal resuscitation guidelines which come up. So in the guideline 2020, 2015, the termination of resuscitation was done from asystole to around 10 minutes. So whenever asystole means that the baby's heart rate is 0, and from that point you are continuing resuscitation, and if you continue for 10 minutes, then you can stop resuscitation. But in the 2020 guidelines, there was a modification because some of the units who are dealing with very small babies, maybe babies who are 800 grams, babies who are 600 grams, sometimes they also sort of come back after 10 minutes. So now the recommendation is that you should stop resuscitation after 20 minutes of asystole. It is not 20 minutes of start of resuscitation, it is 20 minutes of asystole. That is on the point where your assessment says that the heart rate is 0 and it's not improving. From that point, you may give up to 20 minutes and then call it a day.
How do you, for example, if you don't have ECG facility,
Then
maybe
we have to auscultate.
auscultation, would it be very accurate to say when it became 0?
Yes. So the ECG is again more important for very small babies, but 90% of our units we would auscultate. But definitely the cord pulsations are not a good way to assess the heart rate. So you should not look at the cord pulsations. Look at the dedicated auscultation, and when on auscultation you don't find any sounds on auscultation, at that time you can consider that as asystole.
Dr. Ashish, could you elaborate a little more on the oxygen? What is the harm caused by the high concentration oxygen?
Yeah.
Why should it not be given?
So we discussed, and you also discussed in your talk, that the babies who are less than 35 weeks of gestation, they should be all started on room air when you are resuscitating them. And only babies less than 35 weeks of gestation, you may use small amount of oxygen, that is between 21%, which is room air, to 30%. Now, what happens if you give more oxygen to these babies? When you give more oxygen to these babies, I showed you the two mechanisms. One was the primary injury and second was the secondary injury. So the secondary injury, the major contribution in this secondary or the reperfusion injury is the free radical injury. So when you give more oxygen, there will be generation of free radicals, and these free radicals will further cause damage to the brain. Moreover, they are seen to cause later in the life lot of complications like increased chances of leukemia, increased neurodevelopmental delay, and severity of brain damage also increases. And that's why we should never give oxygen unless it is required in these babies.
Thank you, Dr. Ashish. Are there any other questions? I think your talk was very, very clear. They have got their take-home messages very loud and clear. I hope the post-test, I don't see that variation. Shall I, quickly show you the pre-test? Then quickly you can comment on. If you have time, Dr. Ashish.
You can share my email. They can also write me any questions if it comes to their mind later on, or when they are actually managing babies, they can always contact me, ma'am. You can share my number and email, please.
Okay, okay, thank you so much. I think with this, we thank you very much. Sorry for this bad air quality, and my throat has gone. Thank you very much for taking out for us, sharing your the experiences are equally important. I find, evidence is there. We all know about the evidence, but many times we don't get the confidence, if we do this, what will happen. When it comes from experts who is directly handling and has wide exposure to different kinds of situation, it instills confidence in the minds of the people who are especially working at peripheries with resource limited settings. I think with this, I thank you once again, and we look forward. The YouTube link has already been posted. The lecture will be available on the YouTube. You can, those of you who missed any part of the lecture can go through that, and I think presentation is also there. Uh, we would like, please attempt the post test as well. So this will help us in understanding how far we could achieve the objective of our session, and how far what areas we need to still work on. And also we look forward to your feedback about suggestions for future topics, although we have already got a list of for the entire year here. Next would be approach to management of respiratory diseases. Newborn, somebody has written newborn. What do you, newborn care? What do you want here?
Care at birth, maybe he wants care at birth.
Yeah.
Yeah.
I think no, it's all right if you tell us what are the areas where you need hand holding, or you need experts experiences here. We will be happy to provide with you, because this is Dr. Ashish, this is an endeavor, a joint endeavor with our society of NHSRC, because we have several of these guidelines, but they don't reach the peripheral level. So this is a kind of a national level implementation attempt that we try to promote the standard treatment guidelines, and we bring in consistency in care. I think Dr. Ashish has already given you your name. Okay, phone number is there. Okay, thank you so much.
Thank you, ma'am, and my pleasure being here.
Yes, same here. We'll look forward to your continued contributions.
My pleasure. Thank you, ma'am.
Okay, thank you.
Thank you, sir. Thank you, ma'am, for the very informative session.
Please provide the feedback. Do fill the post-test link form. Without that, you will not be able to get the certificate. Feedback is also important for us. Then we know exactly, what is it that you are looking for. We've got a very few feedbacks so far. Please do that also. It is not so important for you, but for us, it is quite important. Siddhi, I've sent you the links to the pre-test and post-test. This is the editable link. Okay, that will help you in working out those who attempted both pre and post-test. I've sent it to the Annapurnas. I didn't have your email on that. So you can
Okay.
ask Annapurna to forward it to you.
Okay, ma'am.
I think
Okay,
if it
I will
is
do that.
done, you can wait for some more time to get the feedback and the post-test link
Yes, ma'am. Yes,
there.
ma'am.
Just because not many people have filled it. Uh, only 22 responses so far for this, and for feedback, only 20 people have given the feedback. Please, we would like to have that helps us, keeps us also motivated to continue doing these.